Dear friends, in this video, I am going to talk about the importance and the methods of prone positioning in ARDS. We all know that prone positioning is necessary for ARDS, and if prostration is an expression of surrender to the higher power, then pronation is an experimentally confirmed truth of improving the lung oxygenation in ARDS. Let us start with a case. A 40-year-old male with respiratory distress following a short bout of viral illness for 3 days presents to the emergency with a heart rate of 90 per minute, blood pressure of 130/70, respiratory rate of 30 per minute, and saturation at room air of 85%. The chest X-ray shows bilateral non-homogeneous opacities with infiltrates. The patient is started on antibiotics, Tamiflu, oxygen by mask at 6 liters per minute, but there is no improvement. And after 24 hours, the patient is put on HFNC because the SpO2 by FiO2 ratio is still less than 250. Even after HFNC, the patient shows no improvement, and therefore the patient is intubated and ventilated and taken on pressure support ventilation with PEEP and FiO2 of 50%. Further to this, also the patient doesn't improve and the patient is taken on controlled ventilation with a rate of 16, inspiratory pressure of 12, FiO2 gradually titrated and increasing up to 90%, the PEEP of 14. But there is still no improvement even after neuromuscular blocking agents, and patient is in a state of refractory hypoxemia. Now, how will prone positioning help this patient? We know that in prone positioning improves the physiological gas exchange in a number of ways. First of all, it improves the ventilation perfusion matching. We know that normally when a patient is lying supine, the ventral surface of the ventral part of the lungs is ventilated better and therefore the oxygenation is better. But that part has a poor perfusion. The dorsal part has more perfusion but is poor in ventilation. So this is the cause of ventilation perfusion mismatch. When the patient is turned prone, automatically when the dorsal part becomes independent of gravity and the ventral part becomes dependent, the perfusion, which is dependent on gravity, improves in the part which was earlier poor, and ventilation improves in the dorsal part, which is now become ventral, and therefore there also a matching between ventilation and perfusion occurs. So therefore the mismatch which was there in supine position gets corrected in case by turning the patient prone. Secondly, because the diaphragm, which in supine position lies in a mechanically disadvantageous position, comes to lie in a mechanically advantageous position so that it can move more freely. So once it can move freely, the lung compliance improves. And because the vertebra, which was earlier placed against the back, was causing an impediment for the expansion of the chest, is now free because it comes upwards with prone position. So the chest wall compliance also improves. Because of the effect of gravity, the secretion clearance becomes easier because secretions can trickle down following the normal airway passage. Then the heart and the stomach contents, which give pressure or which causes compression of the ventral lung, is relieved of that pressure. And so that part is better ventilated. And when this lung, the stomach and the heart contents give pressure, there is a pressure gradient between the dorsal and the ventral part of the lung. Ventral part is better ventilated. The dorsal part is poorly ventilated. So this pressure gradient is responsible for ventilation-induced lung injury. Now, that is also reduced. And of course, the recruitment of dorsal lung regions also improves. So overall, if you look, we can say that prone ventilation is a perfect way to provide lung protective ventilation. This has been seen experimentally in studies, including imaging studies, that during both supine position and prone position, the changes actually corroborated to the physiological changes. That is, the clinical manifestations do occur as expected due to the physiological changes. And the aeration and the ventilation perfusion ratio, this distribution, are more homogeneously distributed throughout the lung during the prone positioning. Therefore, this kind of the non-homogeneous distribution of the ventilation perfusion mismatch, which was occurring in the supine position, gets largely compensated in the prone position. It has also been found that when the different PEEP strategies are combined with the prone position, that limits the mechanical power. So once the mechanical power is high, the chances of ventilator associated events is high. So the ventilator induced lung injury, etc., is closely related with the increase in mechanical power. Now, since prone positioning along with moderate level of PEEP is able to reduce this mechanical power, therefore, automatically the chances of ventilator associated events, including the ventilator induced lung injury, is largely reduced. So if you go by the indications all follow the studies that started with Proseva, and followed by that there were other studies and meta-analysis too. So when patients are having a moderate to severe ARDS with a PF ratio of less than 150 and the requirement of FiO2 is more than equal to 0.6, then they are the candidates for prone positioning. It should be started early in the course of the disease to get the best results. Ideally, within 48 hours, following 12 to 24 hours of mechanical ventilation, allowing for treatment optimization. And it has also been seen that the best outcomes are achieved when we use a tidal volume of 6 mils per kg of predicted body weight, and also use neuromuscular blocking agents in the event or evidence of ventilator dyssynchrony. There are contraindications too, primarily if there is a spinal instability less than 24 hours post cardiac surgery, open chest, post cardiac surgery, or trauma. So these are the absolute contraindications. But there are lots of relative contraindications which are very important to realize, particularly the raised intraocular pressure, raised intracranial pressure, raised intra-abdominal pressure, multiple trauma, severe facial fractures, frequent seizures, severe instability, that is hypotension, hemodynamic instability, etc., morbid obesity, pregnancy second or third trimester, etc. So after excluding all those absolute and relative contraindications, the patients should be subjected for prone positioning in ARDS after if they fulfill the indications. It is very important to have a know-how of the equipments that should be ready before making a patient prone, and when and how to use them, and how best to use them. A lot of times it is seen that low air loss mattress or kinetic therapy bed or its equivalent is used. Although the initial ProSeva trial used normal ICU beds, but low air loss bed system is frequently employed nowadays in the ICU. And because the certain parts of the bed actually inflate and deflate, so the pressure gradient shifts, so the chances of any bed sore is much reduced. However, to add that, we have to understand that there are certain normal pronating ICU beds, but so far those pronating ICU beds have not been found to have any extra advantage over the other beds in reducing bed sores or in making things simple. But one should have a knowledge of what are the things required to make the patient prone, and one can follow a checklist like it is shown in this slide to use to their best of abilities. And after a practicing continuously few times, it automatically gets imbibed in the mind, so it becomes easy. A preparation is very necessary because of before turning the patient prone, well, a multidisciplinary discussion needs to be undertaken with the primary physician, the intensivist, etc., to understand the potential risks and benefits of prone ventilation with proper information to the patient's relatives, and we have to counsel them. And most importantly, one should ensure availability of adequate number of staff to facilitate the procedure safely. The difficult airway trolley should be checked, should be available. Closed circuit suctioning should be there. Patient should be pre-oxygenated with 100% oxygen on appropriate ventilator settings. All lines should be sutured and secured. Patient should be administered adequate sedation and analgesia to maintain a RASS score of -5 if possible, and also to consider muscle relaxation. The eyes should be cleaned, lubricated, and taped to prevent drying and ulceration. Nasogastric feed should be stopped at least for 1 hour before turning the patient prone. The chest drains should be secured and placed below the patient. Urinary catheter should be spigoted and taped to the inside of the leg. Now, all these preparations are important so as to prevent any unforeseen complications which may occur if they are ignored. Ventilator, one has to remember, should be as close as possible to the patient on the appropriate side, and the patient has to be rolled over to the ventilator. So this is also a very important point one should take care during the preparation of the patient. Now, first is the turning the patient from supine to prone. Minimum of 5 people are required, 2 on either sides and 1 physician at the head end, who is the airway doctor. And the airway doctor is responsible for coordinating the entire procedure, although other team members should also understand their role. In cases of prone positioning, usually it is not, there is no requirement of anybody at the foot end of the patient, but if the patient is having too many of chest drains or ECMO cannulas, etc., then probably more staff should be required to handle them. Positioning, you have to remember that patient should be laid flat with the bed in a neutral position, and the slide sheet should be beneath, because that sheet will be used to turn the patient prone. The arm closest to the ventilator is tucked underneath the buttock. That is, if the patient's ventilator on the right hand side, then the right arm should be tucked, as you can see, beneath the buttock, with the palm facing anteriorly. The anterior ECG electrodes should be removed. Pillows, if required, can be placed over the chest, iliac crest, and the knees according to the patient's body habitus to reduce pressure placed upon the abdomen. Now, very important thing is the wrapping of the patient, because a clean bed sheet should be placed on the top of the patient, leaving only the head and the neck should be exposed. The rest all should be covered. Now, these edges of the top and bottom bed sheets, because there is one sheet at the behind also, which I have told, that is the underneath, there should be rolled tightly together, like you can see in the slide side. They should be rolled together, thereby encasing the patient between these two bed sheets and keeping the pillows in the correct position on the top of the patient. So nicely you can see that they should be rolled from both sides. And after that, it is important to notice the horizontal move. Now, keeping the bed sheets pulled taut and the edges rolled tight, the patient should be moved horizontally to lie on the edge of the bed. And the direction of the horizontal movement should be away from the ventilator in the opposite direction to which the patient will be turned, so that it becomes easy. After that, it is the lateral turn, and on the call of the person at the head end, who is the airway doctor, while maintaining a tight grip on the rolled up sheets, the patient is rotated at 90 degrees to lie on their side. So that is why it is the lateral turn. After that, the staff on either side should adjust their hand positionings, because once patient is in, so you can see these staff who are toward the right side of the patient, their hand is going below, and those who are on the left, their hand is going up. So now they change their position of the hand. That is, these hands go below and these hands go up. So after that, on the call of the airway doctor, the rolled up sheet is pulled up from beneath. So it should always be the limbs first, then the abdomen, then the chest, and finally the head. So, and the patient is carefully turned into the prone position. Carefully support the head and neck and turn the head to face the ventilator as the patient is moved from the lateral to the prone position. So if this ventilator was on this side, on the right hand side, now the patient turns his head towards the right side. Ensure that the endotracheal tube is not kinked and a CO2 trace is present. Note the length of the ETT and the lips, and review the ventilator settings. Once you have done that, we can reattach the ECG electrodes and establish all other monitoring. So now we can consider as proning to be complete, but everything is not completed just because patient is turned prone. The positioning needs to be taken care of. Ensure that we have to ensure that the patient is in the center of the bed. Then we remove the slide sheet, that is the sheet which was below the patient and which has come up after turning the patient prone, to ensure counter traction to prevent the patient from slipping off the bed. An absorbent pad should be placed on the under the patient's head to catch secretions, because by gravity the secretions will gradually fall. Now they will come out of the mouth. So absorbent pad should be there, and carefully position the arms in the swimmer's position. So the patient's head is turned in this case to the left or whichever side. So the arm on that side should be to the side, and the arm to the opposite side we should be to the opposite side should be turned towards the patient's side. That is called the swimmer's position. So one arm up and one arm beside the side. One the facing towards the ventilator is up, and the one which is opposite end of the ventilator is towards the side. So the shoulder should be abducted to 80° and the elbows flexed and 90° on the raised arm. Now this is the perfect swimmer's position. Now the position of both head and arm should be alternated every 2 to 4 hours, and patient should be nursed at 30° in the reverse Trendelenburg position, that is the head up position. So we have to take adequate care of the pressure points, ensuring optimal positioning of the pillows tailored to the patient's body habitus. Pressure areas should be meticulously checked. There should be no direct pressure on the eyes. The ears should not be bent over. ETT should not be pressed against the corner of the mouth or the lips. Nasogastric tube should not be pressed against the nostril. Penis hanging between the legs and the catheter should be secured, and the lines and tubings should not be pressing against the skin. Now, where exactly to position the pillows? There are 3 positions where you need to put the pillows. One is across the patient's chest, because that allows the breasts to be supported and free from pressure. Across pelvis to ensure that the abdomen is free from compression, and under the shins to prevent hyperextension at the ankle and minimize pressure exerted on the patient's knees. What should be the duration of prone position? The criteria fixed by the Proseva study for discontinuing prone positioning required the PF ratio of more than 150 on an FiO2 of less than 0.6 and PEEP of less than 10 centimeter in the supine position. It has been shown that the duration of prone positioning for more than 12 hours is associated with better outcomes. Majoritarily, it is done for 16 to 18 hours. A PF ratio deterioration of more than 20% relative to supine, or the occurrence of life-threatening complications, arrhythmias, hypotension, etc. during prone positioning suggests that the same should not be repeated. One major point which was observed in the Proseva's trial was that prone positioning was done every day, even if there was no improvement in oxygenation during the previous sessions, and it went on to give a mortality benefit of 16%, which is tremendous. So mechanisms, this implies that the mechanisms explaining the outcome improvement are complex and not just limited to the improvement in the gas exchange. So overall, it may be the reasons other than gas exchange are also responsible for giving the total huge benefit that is observed in these patients. Some people also advocate extended prone positioning for more than 24 hours. There are certain benefits, there are certain risks too, and benefits are reduced mortality, although questionable, avoiding de-recruitment associated with turning over maneuvers, reducing the ventral pulmonary unit's over-distension, which can occur, and organizational benefits. The risks are pressure injuries and plexopathies, increased risk of CRBSI, and potentially hampered by enteral feeding. So one has to benefit the risks and benefits, and only when the benefits outweigh the risks, such a thing should be considered. But there are proponents who consider extended prone positioning for more than 24 hours too. There are 2 possible implementations, that is prone until clinical improvement, or they can be fixed increased duration up to 48 hours. So either of the 2, but I think more work is required to justify this for the future. Regarding the concomitant therapeutics, the prone positioning reduces the regional heterogeneity, decreases the chest wall compliance, which allows increases in PEEP, thereby improving lung recruitment. The mechanical ventilator settings should be re-evaluated in the prone positioning and after returning the patient supine, and sedation and neuromuscular blocking agents are often employed to prevent the dyssynchrony. There can be adverse effects if properly the steps are not followed and if care is not taken during the entire process. One, there can be unintentional extubation, there can be eye complications, there can be lymphatic obstruction, macroglossia, possibility of venous air embolism, etc. One thing we should remember that whenever the patient develops a cardiac arrest, the patient it is clearly the recommendation is that the CPR should continue in the prone position. One should not attempt to turn the patient supine and then start CR. CPR should be started and should be continued in the prone position itself, and the same can be beneficial. So my final take-home message is that prone position in ARDS has a lot of advantages, and these advantages should be reaped for when a patient is having refractory hypoxia and satisfies the indications for making the patient prone. The improved lung perfusion is one where prone positioning helps because of redistribution of the blood flow more evenly throughout the lungs and thereby reducing the VQ mismatch, which is characteristic of ARDS. It causes enhanced gas exchange by improving ventilation and perfusion. So there is better oxygenation and better removal of carbon dioxide. By reducing mechanical power, it can reduce the ventilator-induced lung injury. And also because the pressure gradient between the dorsal and the ventral regions of the lung is reduced, the shearing force is reduced. So this decreases the strain on those lung areas, and there is uniform lung mechanics all over the lungs. The mortality benefit, prone ventilation, particularly when used early for extended periods of 12 to 18 hours, can significantly reduce mortality in moderate to severe ARDS. There are other potential benefits also, like it can improve the secretion drainage, enhance heart function, and because the work of breathing is reduced because the diaphragm is in a mechanically advantageous position when the patient is in prone position. So that extra benefit can also be gained. So this is all about the importance of prone positioning in ARDS, how it should be done, and what should be taken care of. Thank you very much.